for like stimulating our session today, and in the end, you'll have a chance to ask questions. So our presenters are going to have a brief session of 15 minutes. I ask them to really stick on time so that we have ample time to do our discussions. And so that you give yourselves moral support up here, I'll call all you four to step up and occupy the seats while your presentations are getting uploaded. So I would like to call upon Henry Mazunda, who will start us off with the presentations. Henry is coming from Tanzania Health Promotion Support. He's the Communications and Advocacy Manager. A round of applause for Henry as he's coming up here. And then Sunday Bebwa. Sunday, are you here? Yes, Sunday is coming from TCDC, but currently works at Amref. And so please be here. He's a social behavior change communication technical advisor at Amref. And then we have Professor Henry Molel. A round of applause for Professor Henry Molel from Zombe University. He's the PI for Project ECHO and the Ministry of Health e-learning platform. He's a health systems management specialist. Makofi. And last but not least is Singwa Kaale from MDH. He's also a public health knowledge management and communication specialist with over 10 years of experience in designing and executing multi-channel communication strategies for international health programs and donor-funded programs. So another round of applause for our speakers and presenters. And without wasting time, I will call upon Henry Mazunda, who will be sharing insights on strategic communication and media engagement, highlighting how media partnerships expand and reach impact. So the floor is yours, Henry. You can, I don't know the modality because I know you have a presentation, but you can take us through while sitting here, but you can use any modality you want. It's 15 minutes. And you have our
Yeah, thank you very much. Good afternoon, ladies and gentlemen. So it's my pleasure to make this presentation on amplifying impact, reaching audiences through strategic communication. So I'll be taking you through how Tanzania Health Promotion Support uses strategic communication to reach communities and ultimately improve health outcomes. But allow me to give a brief introduction about who we are and what we do. So, next slide, please. So, Tanzania Health Promotion Support, THPS, is a local non-government organization registered under the NGOs Act of 2002. Since 2011, we have worked in close collaboration with the government of the United Republic of Tanzania, that is both mainland and Zanzibar, with its ministries and agencies, as well as other stakeholders, to ensure accessible, high-quality healthcare for all Tanzanians. And our major areas of focus are infectious and emerging diseases, non-communicable diseases, reproductive, maternal, newborn, child, and adolescent health, as well as addressing structural barriers that prevent people from accessing healthcare. Now, we do this through strategic collaboration, evidence-based interventions, as well as research-driven solutions. And these pillars guide how we design and deliver our programs. Next slide. Yeah, so this figure here just shows in detail our core business. Yeah, so let's go to the next slide. Yeah, so far, Tanzania Health Promotion Support has supported over 1,400 health facilities since 2011. Next slide. And I've just selected a few figures that gives, or that demonstrates the achievements that THPS has realized for a period beginning April 2024 to June 2025. For example, we have tested over 1.6 million individuals, of which over 20,000 have been diagnosed and linked to ART care. We have also supported in hiring about 2,800 healthcare workers across all across 34 councils in 4 regions of Tanzania. And you can also see here that we have about 184,000 people living with HIV who have been screened for NCDs, of which 5,520 were diagnosed and linked to NCD care. Next slide. Now, coming back to strategic communication. Why does it matter? We all know that health behavior change is critical for disease control. Yeah. However, misinformation and low levels of health literacy often prevent people from accessing care. For example, on HIV, there are a lot of myths and a lot of misinformation going around or making rounds in our communities. For example, to this day, there are people who believe that HIV can be cured by local medicine. The others who say that there's no point of taking ARVs if you're not sick. Yet there are others who say ARVs need to be taken with special foods. So all this misinformation has the potential to cause people to delay accessing healthcare. And in worst case scenarios, this can even cause loss of lives. So that is why strategic communication is no longer optional. It is a catalyst for change. When we share the right information at the right time, we empower people to make right or informed decisions about their health. Next slide. Yeah, now here comes the role of the media. So the media is very critical to this effort because the media influences public perception, reduces stigma, and builds trust. So through the media, we create awareness and create demand for health services. The media also helps us to reach our audiences at scale, both at like in urban areas as well as in remote areas. So we can use the media to reach even in the remotest communities. And during outbreaks, trusted media outlets act as the first line of defense against misinformation and fear. Next slide, please. So at THPS, there are a lot of communication approaches that we employ. But for the purposes of this presentation, I will take you through 3 of them, and that is media tours, media workshops, as well as social media. Next slide. Now, at THPS, one of our signature approaches is organizing media tours to our project sites. Currently, we are working in 4 regions of Kigoma, Pwani, Shinyanga, and Tanga. So every quarter, a team of journalists, from different media outlets, visit one of these regions to see results firsthand and hear stories directly from the beneficiaries whom we have impacted with our services. And these stories are then broadcast across different media outlets, TVs, radios, newspapers, blogs, and social media, reaching millions of Tanzanians across the country. So this transparency builds trust and builds trust between communities and providers, because it reassures the communities that the services we are providing are real and effective. And this information now comes from familiar faces from within their communities, giving testimonies about how these services have impacted their lives. Next slide. Yeah, so for example, after some media engagement activities, we noticed these results in Kigoma and Tanga. The PrEP enrollment increased from about 1,000 in March to over 3,000 in June. And HIV testing performance, actually when we were starting the year, that was in October 2024, we had a target of about 177,000. But by September this year, we managed to reach 275,000 people, which is about 150% increase. But let me be clear on this one. This result or this achievement is not only solely dependent on the media engagement activities. There are a lot of other strategies that were used to ensure that we realize these results. However, media activities helped in creating awareness and demand for these services. Yeah, so media engagement and the other strategies that we use complement each other. Next slide. Yes, so alongside media tours, we also invest in annual media workshops. So through these media workshops, we have trained 30 journalists from prominent media houses, including TBC, Azam, we have Star TV, we have The Guardian, Mwananchi, The Citizen, and a number of online media outlets. Yeah, we have trained them, especially in accuracy, as well as ethics, and in-depth health reporting. So these efforts have ensured that we now have a national network of health-conscious journalists who are now better equipped to explain complex health issues, address misinformation, and provide the public with accurate and actionable information. But these workshops also establish two-way communication channels such that they ensure journalists know where to seek clarification whenever misinformation arises. And the outcome has been an improved quality of health reporting. Next slide. Yeah, so that one talks about the 30 journalists that we have trained. Next slide. Yes, so we have social media. Social media is another very powerful tool, especially for real-time health communication. Yeah, we manage platforms such as X, Facebook, Instagram, WhatsApp, and YouTube. So these allow us to share information in real time and provide timely updates or myth busting, especially when it comes to outbreaks. We are able to easily communicate with the communities through social media. But social media also helps us to promote the services that we are providing. For example, HIV testing, voluntary medical male circumcision, TB, and cervical cancer screening, to mention just but a few. The most important thing about social media is that it is interactive. So it allows us to listen, get feedback, as well as adjust our interventions where necessary. So the social media has been helpful in ensuring that we respond much more quickly whenever the need arises. For example, during COVID-19, we used social media to dispel fears and also encourage preventive practices. Next slide. Yeah, so a few examples of the work that has been published. The photo on your right there is about voluntary male medical circumcision. The man there is one of the beneficiaries of this service and is on TV there. I think that is Star TV. You know, dispelling fears that are there surrounding VMMC. Next slide. Yes, a continuation of different media news outputs that we had. Next slide. Yeah. Next slide, please. Images of the media tour on your left. That's a media tour in Pwani that we had recently. And on your right, the photo shows the media workshop that we had with journalists. Next slide. That's the media tour in Kigoma. Next slide. Yeah, so these are some of our beneficiaries who are going about with their activities normally, despite their HIV status. You know, so some are, you know, doing small-scale businesses. Others are working. There's a young lady there who uses preventive methods, PrEP, as well as condoms. Next slide. So, what have we learned? What lessons have we learned? First is that human-centered storytelling works better than technical jargon. People always relate to real-life experiences. But we have also learned that journalists need not to be taken just as coverage tools, but as long-term partners. Again, proactive engagement is very, very important, before, during, and after any health initiative. And social media need to be well moderated to counter misinformation. Next slide. What are our recommendations? Looking ahead, we recommend that it is necessary to institutionalize regular media tours across all projects, because this has proven to be effective. We also need to expand health journalists training, even to regional and council levels, so that accurate health reporting reaches every corner of Tanzania, not only at national level. But we also need to invest in digital literacy, as well as AI-based communication tools. We need to strengthen multi-sector collaboration, media, health, technical, community actors. These need to work together to amplify our collective impact. Next slide. Yeah, what is our call to action? Let's communicate to empower, collaborate to amplify, innovate to transform, because together we can change health behaviors and ultimately save lives. Next slide. So as I conclude, I would like to encourage all of you to visit our website at www.thps.or.tz, where you can learn more about us and what we do. Thank you very much for your attention.
Another for Henry. So thank you very much. Now, next we will hear from Sunday Bebwa, who is going to present on the power of multi-partner collaboration to drive social and behavior change in health. So welcome. I hope you've uploaded his presentation, and pay attention to time. I know we have our timekeepers who are signaling, so maintain an eye contact with them.
Thank you. Yes. Good afternoon. Yeah, I'll take you through the presentation on strategic approach, engaged community for impactful cholera response in Simiyu region. Next. So this is just an outline of the slides. Next. Yeah, we are implementing a comprehensive care and treatment project in Simiyu and other parts of the country, including Mara and Zanzibar. Next. Yeah, we had an outbreak of cholera in the Simiyu region in 2023-2024, and you can see 5.9%, but again, sanitation access is about to 40.6%. And when you are looking at these statistics, please focus on the total population of the region, which is 2.14 million. Next. Yeah, and if you are to now reflect on what I was saying, you can see what is being used in the region through that image, which is the by the time we entered to assist the region, cholera cases had risen to 2,600, and we had 21 death cases for the general population. But again, when we went deeper to the risk population, particularly people living with HIV, we had 56 cases, but with 8 deaths. So you can see how impactful it was to the population that we are saving in the region. Next. So the impact of this outbreak was on resource diversification, as the region and facilities had also to merge some resources and encounter strategies to overcome the outbreak, but again, health systems were overburdened. Next. So what were the communication roadmap that we adopted? We had to come out with the model, which was named as Ngwano Gwalela. This is a Sukuma word, which means Lamgambo. So we had to take lead to combine our efforts so that we manage the outbreak. And our communication included interpersonal communication, mass media, but again, we did advocacy to engage policymakers. Next. So again, why did we communicate? We were communicating purposefully for behavior change, and that was to contain the cholera outbreak, and that is social behavior change. Next. So these are the components of the model. Ngwano Gwalela model had 4 components, which included community health workers mounted with border riders, but plus PA systems with messages to deliver to the community, but with also some water treatment tabs. But again, we had local media engagements. We used mass media, social media, but again, we engaged even the media personnel themselves to advocate for behavior change. We also had a strong collaboration and involvement of the LGAs that included RHMT and CHMTs. But again, we engaged influential people, some engagement with religious leaders through churches to ensure that they deliver appropriate messages to the community. Next. And we also had to orient CHWs and border riders on WASH messages, and we got these messages from health promotion section, which were approved, but again, since we were serving the local communities in the region, we had to tailor messages into Sukuma languages in collaboration with RHMT and the CHMTs. Next. So you can see we were distributing working tools to CHW and border riders. Next. The results up to August included 20 CHW and 20 border riders who were engaged, but again we had 15 media personnel, and also 25 religious leaders, 2 community radio stations, 10 traditional healers, 20 local government authorities from the wards that were mainly affected by the outbreak, but also we also supplied 30 set of washing facilities to RHMT, CHMT to support cholera treatment centers, and we also had to concentrate on the cancers that were contributing to many cases, and these included Itrima, Bariadi DC, and Bariadi TC. Next. Our key achievement included a number of people who were reached, about 15,000. But again, we were able to use CHW to inspect 1,200 water sources, where 900 water sources were treated. Also, 193 households were decontaminated because they produced the cases. And we also had to assist community to establish local washing facility, the Kibuyu Mchiliz, about 800 people. And we distributed also aqua tabs. So we were serving also as distribution channel transferring aqua tabs from RHMT, CHMT to the community. Up to February 18th, the region managed to contain cases to up to 0. And by then, cumulatively, we had recorded 4,200 cases. And also 4,242 cases were treated and released, making recovery rate of 99.4. Unfortunately, we had 24 deaths. Next. So our best practice, including resource sharing, because as we are working in a limited resources, we could not prosper for a longer period of time. So these equipments that were purchased were also used by other partners who came in to also contribute to the efforts of the region, but at least we were the drivers of the motion. And we also saw some elements of sustainability as Barrier DC managed to budget and procure some additional PA systems in order to cover more wards. Also, we are using these equipments currently to address other health challenges. Lesson learned included multi-sectoral joint collaboration is pivotal for community level outbreak management. But again, when we engage local government authority, it becomes easier to understand the magnitude of the challenge, but also enforcing law and making proper planning. Again, we also know that risk perception was initially low, but continuous SBC is essential to curb the case for growth. Next. So we had some few challenges, one being limited resources, and that's why I said we had to concentrate to councils, but again towards which had many cases. But again, we had adverse weather that included rainfall, so we had to plan in advance, but again to compensate for time and days that we could not reach the community. Next. So in conclusion, community-led approach demonstrates effectiveness of cultural ground, multi-sectoral, and community-driven. And that's why you can see we engaged various range of stakeholders from the community, but again, leveraging from the community structures. If there are traditional healers existing, if there are religious leaders in the community, but again, the formal structures that are existing are to be engaged. But again, behavior change strengthened WASH practice through awareness and practical action to the at the community level. So, Ngwano Gwalela model as a replicable and scalable model for health intervention in other regions across Tanzania and beyond, particularly in settings where infrastructure is limited, but community strong, spirit is strong. So this model can be scaled up, but taking into account human-centered design approach. So if you have take it to another region, take it to another community, you have to consider the community itself if it had to work well. It is both a call to action and a testament to what can be achieved through collaboration, innovation, and community ownership in public health. Thank you.
So thank you very much, Sandy. And I want to remind you that you'll have a chance to ask questions. So we've heard from Sandy, from Amref, talking about the power of multi-partner collaboration to drive social behavior change. And Henry reminded us on strategic communication and media engagement to drive public health, outcomes. So keep your questions so that when we finish, all the presenters, after they finish, you'll get that chance to ask questions. I wanted to post that reminder to you. So next, let us take the train, the SGR, to Morogoro, to Mzumbe University. So picture yourself, you're there, where Professor Henry Mollel is going to share with us digital learning approaches, including scalable models like Project Echo and the e-learning platform from Ministry of Health. So, Professor Henry, the ball is yours.
I will also join my previous speaker to stand up. I will feel more comfortable.
I think you can use this one.
Yeah. Good afternoon. I would like to take this opportunity to present the result. In a way, the huge investment that the project that was supported by CDC with funding from PEPFAR has enabled us to put a lot of investment that can be leveraged by other projects in implementing, actually ensuring knowledge sharing, but also building capacity of our health workers. As we know now, the country has invested a lot in building infrastructure, but now we are focusing on how can we, the main focus now, while we continue investing in infrastructure, the focus now should also be on the quality. And the quality, we can only attain quality if we have a competent human resource who can deliver the quality service. So next. Next, please. We actually supported the government because it was our project focused mainly on health system strengthening, and we supported the e-learning platform, and as we are all aware, we have moved it to task sharing, and I think most of us are aware of NIMAT, and we introduced, initially NIMAT was, the training was done on face-to-face, but we introduced a platform. We translated the material to be offered online, and that has enabled us to really train a large number of people in a short period of time. But also with a very cost-effective way. Next, please. So what we actually did, we facilitated the integration of NIMAT into government health system, which is AFIA SS, DHIS2, CTC2. We developed the NIMAT e-learning modules and uploaded into national e-learning platform, coordinated training of health workers, on NIMAT's capacitated IP implementing partners and NIMAT's TOT on the revised NIMAT CPD modules. And a total of 500, we reached the total of 500 as you have seen in the previous slide, which within a short period of time we are able to train at least 2,214 healthcare workers. And this approach has enabled us to reduce costs of training the nurses or NIMAT by 70%. So it's has been a very effective way of training nurses to be able to deliver the HIV services. Next, please. So you could see now, majority of those that we have produced through the program increased the number. Most of them are the ones that are providing HIV and AIDS services. As you could see, the client initiated of ART, majority are now receiving services from those who have been training through the NIMAT's approach. Next, please. Through the platform, the e-learning platform, we connected the e-learning platform with professional councils. And most of people now are enrolling themselves to learn, to be trained or learn through this platform. As you could see, when we received the platform, the situation was the way you could see. We were able to train 18,960, but by the time that the project is coming to an end, we now have been able to train, to provide access to more than 117,798 people. So we have increased the access to healthcare workers who would wish to access the e-learning platform. Next, please. Yes, the total number of health workers, those who have accessed it, how many have been able to utilize? Because you can access, but enroll, but you make use of it to get the benefits that was intended. So the total number of healthcare workers accessed the national e-learning platform is 86,342. The total number of health workers who completed the e-learning course is 60. They have almost 80%. They have been able to complete the courses. We conducted this monthly utilization advocacy session in collaboration with professional councils as a way to sensitize and advocate about the platform, but also disseminated national e-learning platform advocacy material to IPs, LGAs, and the public health institutions. Next, please. Yeah, the majority of those who have utilized the system were awarded because we also accredited the modules. So those who are accessing the modules can now get the CPD. We're able to get the CPD. And as you could see, from 2022, just a year after we started implementing the project, we have been able to now provide CPD points, enable 68,947 people to get their CPD points through the e-learning platform. Next, please. We have analyzed those who have received the CPD points through the platform in relation to professional councils, and you could see those who have registered through the Medical Council of Tanganyika, those who have registered through the Nursing Midwifery Council and the Health Laboratory Practitioner Council. Next, please. This was also possible, increasing the access was also possible because we have supported the conversion of the modules, increasing the number of modules that people can access to the platform, and healthcare workers can now access them. As you could see, we found when we started, there were only 14 modules, but by today, we have more than 275 modules, and health workers can easily access wherever they are. Next, please. So what we could say on this e-learning platform is that it is a cost-effective training method that you don't have to bring people to one place. People can access the learning while they're in their workplaces. It is also allow flexibility in training modules, flexibility. Health workers can study it at any time. Reduces service gaps when healthcare workers travel. We all know that the impact, the effect of bringing people from health workers to one center. You leave health facilities starving while we have severe shortage, and you pull those few workers, health workers who are there for the training. So this provides an opportunity where people can learn while in their work, while they don't have to move from their workplace to be able to get training. Offers access to updated content because the material are updated from time to time, but also enable health workers to obtain relicensing in other professional councils. So this is what we have done in e-learning platform, and the health workers are greatly encouraged to make use of the system, of the platform. And other partners are encouraged also to increase the number of modules so that we could provide more access to healthcare workers. Next, please. ECO platform also has been a very, very useful platform related to e-learning platform. And we have made a huge investment, CDC, through the PEPFAR funding through CDC. We have made a huge investment to health facilities by installing equipment that will enable them to make it effective, get the training, access the learning through ECHO platform. So until now, as you could see from the map, we have, because this involves having a hub that where the sessions are delivered, and having facilities, spokes in facilities where people can access the learning. So this is how the spokes have been distributed. The plus, the red plus indicate the hub, and the other dots indicate the spokes, the way spokes has been spread around the country. Next, please. So this program area focused on supporting the implementation of all ECHO clinics and e-learning in Tanzania, as well as the capacitating remote teaching and mentorship at all levels of the health system to ensure high quality HIV services delivery. The aim is to reduce costs associated with training and bring equality in underserved area. Next, please. So what we could say with this program is moving knowledge without moving people or moving patients. So because it provides an opportunity through telemonitoring, ECHO builds capacity and creates access to high quality specialty care service in local communities. So this provides an opportunity of people wherever they are to gain knowledge and the skills necessary for them to deliver quality services. It also provided an opportunity of networking. Those who have been participating through the community of practice can share knowledge, but there is also opportunity of specialists sharing knowledge to those who are in remote areas who could not probably have no frequent access to be able to be exposed to more updated material. So what we did, by doing so, we now guarantee or ensure availability of right care, right in the right place and at the right time. But at the same time, for the provider, they have been able to acquire knowledge, treat more patients, and build a community of practice. But for the community, reduces the disparities in service delivery, where in places where service delivery was poor, we have been able to improve by capacitating the staff, retain providers, and keep patients local. But through the system, it has increased the access for people to learn, but also improving the services to the people across the country, even in remote areas, improve quality and reduce cost. Next, please. So when we received the project, when we started to implement the project in 2020, we have only 4 hub. We had only 4 hub, but by the time, up to date, we have 18 hubs. And this has helped to reduce traffic, because when you have 1 hub providing access to a large number of spokes, then it becomes a little bit challenging, because it becomes overcrowded and therefore reduces efficiency. So we now have 18 hubs, which is a huge investment that we really need to make effective use of all this investment that the government has made. Next, please. We have also increased the number of spokes. As you could see, when we started the project, there were only 190 spokes, but now we have 454 spokes. Next, please. Next, please. We have also increased the number of clinics. When we started the project in 2020, there were only 7 clinics, but by this year, we have 13 operating clinics. Next, please. So the clinics that Mzumbe University organized and were running, adult HIV, ECHO, pediatric, which has been transitioned for sustainability to NASHCOP. Pediatric HIV, ECHO was transitioned to NASHCOP. Imaging and reimaging of infectious disease, ECHO was transitioned to MNH, blood safety, echo clinic have been transitioned to NBTS. Reproductive and maternal, newborn, child, and adolescent health was transitioned to Ministry of Health, RCH. Mental health clinic, Mirembe, and the cancer echo clinic has been transitioned to Ocean Road. So this is how the echo platform operates. It's not really far from e-learning platform, and provide an opportunity for experts to share experiences, knowledge that have been very useful for those who are frontline service providers. Next, please. So this is just an analysis that the attendance of people in ECHO platform, and the first column, apart from the year, the second column, show a single attendance, and the second column show the cumulative. So some of the people have attended 2 days, two times, the others 3 times. So cumulatively, that is the number the last column is showing, the cumulative frequency attendance of healthcare workers. Next, please. So what are the outcome of the ECHO is that we have been able to establish the HIV community of practice, the TB community of practice, where learning can take place by sharing experiences, and also mental health community of practice. Next, please. Other outcomes: improvement of healthcare workers' knowledge and confidence in the delivery of health services, improvement of patients' health through consultation of complex cases, a strong community of practice and the reduction of professional isolation, a cost effectiveness in training, as we have seen in e-learning platform, and this platform also provide an opportunity of people learning without traveling or without incurring a lot of cost to retain people in one place for them to be able to learn. Professional development and CPD credit linkages. We accredited most of the modules that were developed, and the health workers can now gain their credit points by studying through this platform. Facilitated certification and licensing of program of non-laboratory testers performing HIV rapid testing. Next, please. And this is the end of my presentation. It was just a highlight of the investment that the project has really made, and the other projects can leverage to make effective use of this, but also a call for health workers to utilize this platform and actually increase their competencies, but also get the benefits by gaining their CPD points. Otherwise, thank you so much for the...
Thank you very much, Professor Henry. Please don't go. Finally, we have a very exciting presentation from Singwa Kaale from MDH, who is going to talk on how we can harness technology and artificial intelligence to transform health communication. So this is a very interesting topic. Just remain seated, keep your questions, and we'll discuss right after he finishes. Over to you.
Thank you very much. So good afternoon, distinguished guests, my colleagues, my fellow health communication team, as well as my MDH communication team. First, I would like to acknowledge the presence of my teacher, Professor Mole, 16 years back. So the knowledge that I'll share, some part have been delivered from him, and also if I make a mistake, he's the one to blame. I'm joking. Thank you. Thank you very much. So it's my pleasure to be in front of you today to present a very important and very interesting topic, and actually which is quickly shaping how we connect and how we inform, as well how we save lives. Our topic today is harnessing technology and AI for transformative health communication, which simply means controlling and use technology and AI to improve health outcomes. Yes, so as we see today, many people, especially youth, are engaged in these mobile technologies. That to say, majority of youth are now using mobile phone, especially the smartphone. But as well, they largely engage in social media, online platforms. That to say, smartphones nowadays are very much closer to our life more than ever before. At the same time, there is a fast growing of AI technologies. In fact, every sector now is facing this transformation. So this to say, health communication can no longer afford to be static or traditional. We have to move with this pace of technology. So currently, we are at the joint of innovation and impact, whereby digital tools, mobile technologies, and these AI innovations are not just enhancing communication, but they are transforming how we educate our youth, how we empower, as well. It helps us to find new ways to solve these complex health problems in our society. So in our presentation today, we'll be able to explore some emerging technologies and also unlocking some of the new opportunities for the public health. Especially among youth, which is our focus today, our primary focus today. We will also reflect on how we can harness these tools responsibly, ethically, as well as inclusively, so that we are not leaving anyone behind for the lasting health outcomes. So please, you are welcome. I think you have gone too far. Please, can you go back so that we see the introduction? Back again. Yes, so the focus of our presentation today, we'll try to look on the meaning of health communication. We'll look at the roles as well as the relevance of health communication in the AI technologies. And another thing that we'll check is the technology in health. Here we'll try to see what are the initiatives which have been made by our government and how well we are interacting with these technologies vis-a-vis the mobile innovation, youth, as well as health service accessibility. Another things, we'll try to see the definitions of artificial intelligence, AI, and also the practical application of this AI technology in health communication. As well, we will go through to see the case studies of one of the AI application that have been invented. We call it Maiwango. We'll see the details as we go far. As well, we'll find the time to see the key findings of these applications and see how relevant it is. And lastly, we will see the future of AI in health communication. Please, next slide. Yeah, so as I have highlighted, health communication is not a new phenomenon. It's just a use of messages and health communication strategies to inform, to influence, as well as to influence decision-making so as to improve health outcomes for our communities. It involves sharings of accurate health information and to promote health behaviors and practice. So directly we see that health communication, it influences behavioral change communication. Next slide, please. So in a nutshell, the laws of communications, I have categorized it into 5 points. First, it improves health literacies. It is a way to raise awareness and to impact knowledge to the community. But as well, it is a very good tool to combat misinformations because by interacting with health communication, people get knowledge and they clear these misinformations. Third, it supports the prevention and disease controls. In so many ways, we use health communication in tackling some outbreaks. Some of the examples have been said by previous presenters. Another thing, it influences police and advocacy. The results that we are getting on this health communication interaction, it helps in policy analysis as well as refining these policies so that to lead us to the good health outcomes. And lastly but not least, it supports behavioral change communication as highlighted in the definition. Next slide, please. So what is the relevance of health communication in this technology area? So we see that if we interact with these digital eras, we found that we will reach a wider area of community. Another thing, it is real-time communication, that people can get information instantly. And another thing, there is a room to customize this message when interacting with AI. So you can focus on the target audience in terms of age, location, or behaviors. These AIs now can interact with youth in their languages. So it is easier for them to be part of the learning process through this AI. As well, it increases youth engagement, as we see that youth are highly digitally connected to these technologies. Another thing, it is cost effective. Instead of printing the billboards, using a lot of cost, if we use this, it minimizes the costs. As well, it can support behavioral trackings and provide feedback, which will also help in decision making. Next slide, please. Yes, so the technology in health has been grown very rapidly. For example, in Tanzania, there is significant efforts which have been made by the government. And we can see now we have so many applications which are very well used, and they are producing very, very nice outcomes. To mention a few, we have this ELMS application, which is meant for commodities in supply chains. It is now used countrywide, and we have also DHIS2, which we get some health information, data reporting. As well, we have this hospital management system, which is now introduced in our country, and it is being used. But we have SMS services. We have this application called M-Mama, which is working very greatly on the issues of reproductive health. But the bigger things now, we have national strategies which supports the use of technology in our country. In 2019, Tanzania have invested this digital health strategy, which is operational to date. Another slide, please. So I'm trying to highlight the penetrations of this mobile technology vis-a-vis digital health accesses. So nowadays, the use of mobile phones are very much closer to use than ever before. It's a very great companion, more than the interaction between youth to youth. So it is a loophole to impact some knowledge in these smartphones, so that youth, when interacting with the phones, then they get this knowledge they wish to have. So if we go to the statistics, we found that more than 25 million are using these mobile phones. This is the statistics from 2023. And majority of these people who are using these mobile phones are the youth. As well, nowadays, owning a phone, it is a bit easier than before. So many youth can be able to access these phones. As well, the bundles for internet, every day they're becoming better and better way up cheap. And if over 30 million now people can access internet with this growing rapid rule of 4G expansion. So yes, majority of the people can access. And as we can see in our NGOs, all of the NGOs, now we are interacting with social media, and we are posting some of the important health aspects in our social media. So 82% of youth now, they can access mobile phones, but 31 can access smartphones, which they can be able to get this information. So on the board, it's just a health communication ecosystem. It shows how we interact with mobile phones, social media, as well as emerging technology of AI. So in a nutshell, artificial intelligence is not a new thing, but it is just an ability of a machine or a computer system to perform tasks that normally require human intelligence, such as understanding some languages, making decisions, and the like. So AI makes health communication faster, accurate, and also it avoids this, the bias of inclusivity. Anybody can access this information wherever they are. So application of AI in health communication, it makes health information more accessible, timely, and personalized. It supports health professionals delivering the right message to the right audiences. So the interaction as well, it improves patient engagement, as some of these AI interventions, they lead to referrals. So when people engage, they can get referred to the nearest health services to get services. So also the ethical and data privacy, next slide please, and data privacy is being considered during these AI interventions to ensure confidentiality as well as safe handling of sensitive health information. And another thing, this AI, it is made in a way that it avoids some bias. So everybody can equally access information from AI. Next slide, please. So this is our case study. So at MDH, we have launched this project called Maiwangu. So we have chosen this name Maiwangu, which means something very close to you. It is an AI chatbot digital intervention whereby we have fed some health information in this system. The primary focus is to youth. So youth can get health information by interacting with this chatbot. And we have piloted this to Tabora, Kagera, and Dar es Salaam. We are working in collaboration with the Minister of Health, support from PEPFAR through CDC, and MDH, and our technocrats, TechnoForward. Next slide, please. So we have put 4 areas which we are now dealing with these Maiwangu applications. The first one, we have interacting how to put information on HIV testing. The other area is on HIV prevention, whereby people can get knowledge about condom use, they can get different education, as well as some part of counseling aspect. You can get it through this application. As well, we have some information regarding maternal and child health and mental health. Next slide, please. So key features of Maiwangu. First, it provides accurate and updated health information on HIV, maternal, and mental health. Another thing, it aligns with the National Health Policy, as said, the National Strategic Policy on Communication, on communication, as mentioned before. As well, it emphasizes the confidentiality. Now we are using the hashtag sitakucholesha, which means I will not let down, I won't tell people about your secrets. And another good stuff about this Maiwangu, it is multilingual. You can interact in English and as well as in Swahili. But not only Swahili, but it can use lugha ya mtaani. Whatever language youth can use, it go with that trend. And another thing, it helps to refer people or youth to the nearest facilities to get these services. So the key findings from the pilots, we found that 97% of the youth, they like engaging with this My Wangu application, and they say it is very helpful. As well, they are able and willing to refer to other youth. Some of the feedback from youth, they want this application to include some other topic, like non-communicable disease and others. As well, they wish to have some pictorial presentation in this application, which currently it doesn't have that feature. So in future, we are planning to scale this beyond HIV services, but to national non-communicable disease, reproductive health, as well as to integrate these pictorials as it have been advised by youth. And another thing is integration with health system for stronger referral linkages. So lastly, I would wish to next slide, please. Next slide. Yes, so I wish all of us to try to engage with this. So if you have a smartphone, please, you can check this number and add it in your contact. Or you can just simply scan this QR code and then save this number. So after doing that, you can open the WhatsApp application and you can start chatting with My Wangu. You can ask it in Swahili or in English. You can use any jargon language that you use in your area. So I wish someone who has already interacted to give us the testimonial. And that will mark the end of our presentation. Thank you very much.
Thank you so much, Singwana My Wangu. I'm sure people can relate to that. I see youngsters in the room. So thank you very much to all our presenters. They have done a remarkable job. We give them a very big round of applause. And I know we started a bit late, so we have some time for discussion. So the floor now is on your side. If you have any questions, any comments, this is now your chance to engage. So I will start with this section that is facing me. By show of hands, let me see how many questions do we have. I see 2, 3, 4, 5. Hey, okay. In the middle here? No questions. This side? I see 1. So I'll give you priority to start, and then we'll go to that group that has many questions. So tell us your name and ask your question.
Yes, good afternoon. My name is Florian, and I'm happy to be part of this conversation. And congratulations to THPS and partners for organizing this. So my question, or rather just a point of discussion, would start with Henry. Thank you so much for that informative discussion. Now, you've raised a very key aspect when it comes to communication, especially health-related communication and programming, the issue around misinformation. Now, looking at, with all this holistic approach towards care, now, what would you recommend, or rather see as being an, especially considering the age-appropriate intervention as it being key to enhancing awareness, creating demand, and amplifying access? What would be the strategy toward this, especially to adolescents who are much affected by both cultural and systemic barriers? But two, with the social media coverage, looking at you know, the 35% of most of people being at the areas where we qualify as being urban centers, but we still have more than 65%, to be precise, 65.1% of people still living in rural areas. How are we amplifying this? And especially now reflecting to what Singwa has just ended up with. How are we amplifying coverage, especially considering much segment of the population still live in the areas where are not very much, do not have access to technology and the like. And to Sunday Afya Thabiti, thank you again for that. It's a credible initiative, but looking at it, it's still rather a response initiative, disaster response. We are much keen into responding rather than preparedness. Now, looking at the sustainability aspect of it, what's the plan towards you know, having a preparedness plan, especially to our regions, and not just documenting it, having it budgeted and actually having it implemented. And it was good to see that, for example, Bariad DC budgeted for the procurement of PAs to see how much they can replicate that. But to this effect, how has it been impactful and effective so far, and how can other councillors put into that?
So thank you. I will cut you short. We have been cautioned about time. So you've done 2 questions in a row. So let me hand over to that side. So we get a question. And then if you have further queries, there's always room to discuss outside the meeting.
Yeah, I still had something with Professor, but it's okay.
Okay, all right.
So okay. Let's have others, then we can.
Yes. So Dr. Mashoto. He has asked what you wanted. Okay, thank you. So this person here, and then.
Thank you so much. You've also asked my question, actually. But I did have 2 questions. My name is Julius. I work as the communications officer at Public Health, Government Health Tanzania. So I was really interested in THPS. Mmesema kwamba mna program mnafanyia training kwa waandishi wa habari. What about as youth? Kama mimi, I'm an advocate, I'm taking public health, I deal in communications, and I'm really interested in what you're doing, and I really like to also get more insight ili niweze kukua professionally, but also niweze ku empower my community. Can I get a chance to be trained by you? Unaweza kuwa volunteer, ku intern kuna nyie. But also naomba nikazie kwenye his question, how mmeelezea kuhusu kufikisha to communicate strategically, to communicate strategically and to help communities get better information of health sectors. How about those communities ambao hawana internet access, or hawana access to data, hawana access to mobile phones in the rural areas? How do you plan? What strategies do you have to reach them? So thank you.
Thank you. So now, in the interest of time, and maybe we get democratic here, can we have like 5 minutes to finish everything? I know you have a burning question. He had a question to Professor Henry. If you can also be brief after he finishes, or if you have a question to Professor, then I will not allow you to ask. So go ahead.
Thank you. My name is Cynthia Masuka. I work as a program coordinator from JJ Breastfeeding Organization. I link these questions to the former speaker from MDH and the professor. So from the professor's side, we have training modules on e-learning platforms. So do we have anything on hands-on skills for breastfeeding, or let me say lactation support to healthcare providers? And to the person from the MDH, as a breastfeeding specialist, I had to run so fast to the bot to see what it says about breastfeeding. Congratulations, because it has all the information I needed. But if the app refers a person to the healthcare providers, if the healthcare providers does not have the right hands-on skills So then how can this person get the help that the person needs in order to combat that breastfeeding challenge she might have encountered kwenye safari yake unyonyeshaji? Thank you.
All right. Oh, I didn't see your hand. Okay, sorry. So that will be the last one. And if you are still interested and you don't want to go to lunch, we can extend.
I'll be very brief. Thank you very much, and congratulations to all the presenters. I have a question to Professor Mollel. Really great to see that you have managed to transition all the clinics to specific government entities. I'm curious to see whether you have an opportunity to see how functionable they are, and also whether there is an allocation of funds, for example, for internet and so forth, just to make sure that they're really being conducted on a monthly basis as they used to be in terms of the quality. Thank you.
Okay, now over to you, our dear presenters, and be very, very brief. If you do it in 30 seconds each, I will appreciate.
Yes, if I got you right, you're talking of a breastfeeding module. Am I correct? For health providers. Healthcare providers. That is what I said. We developed several modules, and the stakeholders are still called to produce more modules, especially those who are working in those interventions of that nature, to increase the scope of modules that are available and they can be accessed by healthcare workers. So I have to say, I don't remember having developed an explicit model on breastfeeding. So it's an opportunity for partners who are working on that area to also develop modules and to be uploaded in the e-learning platform. Regarding the sustainability, yes, I would say we started the transition long ago, and the program, the clinics have been run. We have just been supervising them, so they are running, and I assure you that they will continue running, because we have transitioned, and in terms of supporting it with the internet, we actually promoted it, advocated it to health facilities to allocate a budget for supporting the program. So it has started some time ago. The more important is only to continue advocating it so that they will continue with what they have already started. Thank you.
Thank you for the question. Again, it was about disaster response and sustainability element. If you remember, I said we had a population of 2 million, but again we had limited access to sanitation, and so with such fact, we should be reminded that also outbreaks will be possible. But that's why we said we are engaging multi-sectoral approach. And I said engaging the LGAs was for the enforcement of laws, but again, making future plan for improvement of such situation. So our model was a reactive action, but again, in it was some element of proactiveness. That's why you can see the one council had to procure. But again, we oriented CHWs who are in the community. We engaged borders who are from the same community, traditional healers, religious leaders. We believe SBC messages will keep going on to ensure that there is no outbreaks in the future, taking into consideration of policy enforcement and better planning for future improvement. Thank you.
Yeah, thank you very much. I will start with the question that my sister there asked, which in some ways is related to what my brother there asked on reaching rural communities who are limited in terms of communication tools. Yeah, so yes, we know that some people in the rural communities do not own a cellular phone, but we have other available media outlets that are used even in the rural areas. For example, we have engaged with the local radios, which are available in many rural areas. Those ones are able to reach the communities with important health information. But working collaboratively with other stakeholders, we will be exploring, different ways of making sure that rural communities are not left behind in any way. You asked about only training journalists. What about the others? Yes. Yes, THPS, we are training journalists on health communication, but we are also training peer educators who live in our communities and are able to pass on important messages to the target groups. Yeah, but we are also encouraging other stakeholders to join hands so that together we can explore better ways of making sure that nobody is left behind. Thank you very much.
Yes, thank you very much. So the issue of expansion of services, for example, this My Wangu application, there is some few food of thought of how we can expand these services. First, we can see how best we can integrate these services not only in smartphones, but also in these normal mobile phones, maybe in terms of push messages or whatever. But we can also use the loophole of integrating these services to the existing infrastructures that we have. We know that this youth-friendly services project has now been adopted with the government, and almost all health facilities, they have these youth-friendly offices and the like. So it is impossible to buy phones for every youth, but we can think about having a tablet in every facility, which is stationary, and people can be going to that facility, interact with that system, and then go home. So we can think of having maybe 2 or 3 tablets in each health facilities. We can go far by collaborating with the local government, maybe in every ward offices, to have these tablets, and then youth can have access to interact with these tablets and get their answers. But as well, we know that nowadays in, I think, all the health facilities, we have installed these solar panels to make these systems work, like DHS2 and ELMS. Then you can use the same loophole to consider expanding these MyWang services through that loophole. Thank you very much.
Thank you very much, Singwa, and thank you, our dear presenters, for this wonderful session. We've now come to an end of our forum, and I'm sure there's still much to be discussed. I can see all corners still have hands. So this was a very important discussion topic, and we've heard from collaborations, partnerships, and digital platforms, AI, and all these initiatives that need to have communication for public health activities. Quite important, and so much learning from all that you've discussed. Very insightful, I think you can agree with me, very insightful discussions, quite important, all communication strategies that need to be advanced. So to all of us, we take these lessons back to our workplaces to continue and advocate and improve, health communication in public health to ensure the reach is increased and beneficiaries, people we serve, also the numbers that have been projected here are a result of a number of these initiatives that keep on happening. So thank you very much to you all, and a big round of applause to them. And I've been told by the organizers we have a presentation of trophies to THPS and CDC, and Dr. Kijakazi is going to do that. And so maybe we take that chance, and we'll have also a group photo here. We can do that. And thank you so much to you, the audience, for remaining until this time. I know lunch is already served or getting served, but you've shown your interest and commitment to attend this session. So a big round of applause to yourselves. Thank you very much. So now maybe we do that short presentation of trophies, and then we can have a group photo here. So thank you so much. Asanteni sana. And we thank THPS and Amref for sponsoring this forum. Asanteni sana. She's here. So maybe for THPS, since the executive director for THPS is here, Dr. Redemptor, if you can receive the trophy for THPS. So I know someone is coming for CDC. Okay. Oh, yeah. I was told there was somebody lined up. I knew you were not. Okay. Sorry.
So I'm taking this, I'm actually receiving this on behalf of CDC. Before I do that, can I just say something which I told some of our colleagues, that this was a very great idea to have such a session. I think it's the first time we're having a communication session in health, and we can see that it really makes a difference how we communicate health issues in order to impact the health of people. So I'm taking this on behalf of CDC, but we really appreciate for the idea and also for sponsoring, for funding us as implementing partners to be able to sponsor.
So this was a male-dominated discussion. I want to take photos with all the presenters. So this is a personal